Welcome to the Mind Gut Conversation, your go-to podcast for exploring cutting-edge ideas in optimal health and the fascinating science of mind-gut microbiome interactions. I'm your host, Emeran. Here we bring together thought leaders, groundbreaking researchers, and innovative practitioners to share insights that can transform the way you understand your body, mind, and overall well-being. Whether you're a health enthusiast, a curious learner, or a professional in the field, this podcast is your gateway to unlocking the secrets of the mind-gut connection. So settle in, open your mind, and join us as we journey into the science and stories shaping the future of health. Welcome back to the Mind-Gut Conversation podcast. I'm Emeran Mayer, and joining me again today is my son Dylan, who will be asking the questions.
Hey again, everyone. Thanks for tuning in. Today's episode is going to be focusing on topics related to IBS, as April is IBS Awareness Month.
We will be discussing topics that we have both seen frequently on social media from my patients or that I have been asked when giving talks related to the topic.
All right, so let's get into the questions. Firstly, a trending topic we've both seen is this explosion of interest in gut health. Everyone has so many questions related to the gut and their gut health, how to optimize it and how to improve poor gut health. Why do you think this has been happening? Could it be related to the prevalence of IBS or the increasing number of IBS patients?
It is indeed an interesting phenomenon that puzzles me as well, because for a big part of my career, there was no interest or no willingness of either patients or physicians to address this important topic, even though we've studied this over the last 4 decades. I think the recent increased visibility in the media and on social media is related to really the introduction of this concept of brain-gut interactions and of microbiome-gut interactions. Both of these topics have sort of made this more interesting to the lay public and to patients. It's now more acceptable. It's no longer, if you talk about the brain, it's not psychological, it's biological mechanisms that interact with the brain and its microbes and play a big role in IBS symptoms. If you look at the numbers, it's not interesting. It's not related to an increased number of IBS patients. And we'll come back to this in a moment. So when I say IBS patients as defined by validated, accepted symptom criteria, which really limits that population to a very narrow band. So it's more the interest in general of the public, what central role that the gut and diet and things that you ingest, what they play in overall health and well-being, rather than really being an increase in the number of IBS patients. That's my opinion on it.
Yeah, it's interesting to see gut health become like a dinner topic conversation. People talking about their gut issues they're having with their gut. It's become a normal thing to bring up. It's an interesting thing. That definitely gives some clarity on this. So building on that, while there's been a rise in interest around gut health and gut issues, the prevalence of IBS diagnosed by, like you said, the validated symptom criteria or the so-called Rome criteria has been fairly stable over the past several decades. The major reason for minor fluctuation being the revision of these criteria every few years. At the same time, other brain, gut, and lifestyle alteration disorders have progressively increased. Why has this not been the case for IBS?
Yeah, this is another puzzling phenomenon. You would think that a lot of people talk about the increase in anxiety, particularly amongst younger people following the pandemic. And there's a lot of reasons, obviously, for people being more anxious at the moment for the uncertainty of the political situation worldwide, climate change, these multi-crisis situations. And because IBS is so closely linked to anxiety, you're really surprised why IBS has not increased at the same time. And that's particularly surprising because we have seen increase of many chronic disorders that where brain-gut interactions have been implicated. So this chronic contagious disease epidemic that includes a wide range of diseases from colon cancer to Alzheimer's disease to many other diseases from the brain to the body. So why has this not affected the IBS prevalence? I don't have a good answer for this, quite honestly. I think the prevalence of IBS is so much determined by what kind of criteria you use for making the diagnosis. So if you use looser criteria like we've done in the past, including discomfort, bloating, abdominal distension, not feeling well, then obviously there would most likely be an observable increase in the diagnosis. But because it's been narrowed down to chronic abdominal pain, not discomfort, but pain in association with alteration in bowel habits, you leave out a big portion of this whole complex out of the definition. And to me, that's the most likely, the most plausible explanation. So I think all these other comorbid conditions have been increasing, particularly anxiety. We know that from many studies, whereas the limited diagnosis of IBS symptoms has not really changed.
Interesting. So it's more about how we define it and diagnose IBS. Okay, so that leads into the next point, the Rome criteria. So the criteria for a diagnosis of IBS are narrowly defined on chronic symptoms of abdominal pain and alterations in bowel habits. However, a large number of IBS patients experience non-painful discomfort like bloating, abdominal distension, and extraintestinal symptoms, including anxiety. Is IBS just the tip of the iceberg of a wider dysregulation of brain-gut interactions?
Yeah, I think what we are realizing now, and it's increasingly recognized by the IBS research community, that patients with IBS frequently experience these comorbid somatic symptoms, including dyspepsia, so basically pain, discomfort in the upper part of the stomach, migraines, myalgias, muscle pain, anxiety, depression, and poor sleep. As a matter of fact, if you look at the cost for the healthcare system that IBS patients generate, it's generated by these non-gut symptoms to a larger degree than by the actual gut symptoms. And it's also interesting. So these comorbid symptoms are more frequent in women than in men. Many studies have shown that. And they are associated with more severe IBS symptoms, worse quality of life, and increased healthcare utilization. So IBS in that context, if you include the comorbid conditions, it's really a spectrum that goes from mild symptoms of gut discomfort that a lot of people, probably up to 40% of the healthy population, experiences on a regular basis. You could almost say that that's a normal reflection of our dietary habits and patterns. So if somebody eats more, beans and gas-producing food that they would have without really having a distinct diagnosis of IBS, but they would have these symptoms, these mild symptoms. But it goes all the way to the most severe IBS symptoms, severe pain that require, medical interventions, pharmaceutical interventions, or behavioral interventions. So I think we have to sort of, and this will, in my opinion, happen in the next couple of years, that will look at take a different viewpoint on IBS and look at these IBS symptoms or patients defined by the Rome criteria as really the tip of the iceberg.
Interesting. Yeah, that definitely paints a broader picture of what's going on. So now let's talk about something that comes up a lot, anxiety. The majority of patients with IBS have increased levels of anxiety, which may be limited to symptom-related anxiety, or include general anxiety. Does IBS cause anxiety, or is it the other way around? What's the chicken and the egg in this scenario?
Yeah, so this is best answered realizing that the interactions between the brain and the gut are bidirectional. It's not a linear communication system where one part, like the brain, influences the gut, causing the symptoms, or the gut produces chemical mediators with the microbes that affect the brain. It's always this bidirectional communication. So that's one answer to this question. We've also found that in our studies, where we up to really recently have focused on a very narrowly defined IBS population. So, as we mentioned before, Rome criteria excluded patients with psychiatric diagnoses based on questionnaires or in interviews. But what we have noticed that even if we exclude patients that meet psychiatric symptom criteria for like general anxiety disorder, IBS patients still come out on questionnaires to show an increased level of non-pathological anxiety. So it seems you can't really exclude the anxiety from the syndrome. And it's almost like in my opinion, the other side of the coin, that anxiety and gut symptoms are really two clinical presentations of the syndrome. The other part of it is that many patients, it's a symptom-related anxiety. So they are worried, and rightfully so, for example, if they diarrhea predominant IBS, if they get the urge to have a bowel movement that they're not close enough to a bathroom, which creates a tremendous amount of anxiety, which then exacerbates the symptoms and the signals the brain sends to the gut. There's also a lot of symptom-related anxiety related to food. So can go all the way to food-related fears. And that's kind of really exacerbated by the information that IBS patients find on the internet, or even the kind of recommendations they get when they encounter experts in a clinical setting, that all these foods, like the FODMAPs are a good example, are foods that cause IBS symptoms. It may be true that many of these FODMAP items, like complex carbohydrates or lactose, milk sugar, can produce symptoms, but it also creates an anxiety of patients to look at a lot of foodstuffs. Gluten is another good example, that they are likely triggers of their symptoms. If they're really physiological triggers, or if this is related to this food-related fears or anxieties, we don't know this for all the patients. My feeling is that both of these components play an important role.
It's almost like a placebo effect. If you read something that says these 5 foods are going to trigger IBS symptoms or are not good to eat, and you eat something and you're fine, and then you read on the menu this had one of these items, then you experience symptoms. It's almost like you're associating the two.
Yeah, and you could say, if you feel better if you don't eat them, that could be a placebo effect. And if you get worse when you eat them or even just think about them, it's a so-called nocebo effect, that the brain basically sends a signal of warning, of threat to the gut, because it anticipates something bad is going to happen to you. But that doesn't include that there's, beyond the symptom-related anxiety of food-related fears, that there's also patients with general anxiety disorder. What we know today from many studies, epidemiological studies, but also most importantly genetic studies, that vulnerability genes for anxiety disorders are shared with, or that IBS patients share these vulnerability genes with patients that have anxiety disorders, even some psychiatric disorders. So they're not causative, but they increase the vulnerability. If you have IBS, you're likely to have genes that make you more susceptible to anxiety-creating stimuli, and that goes all the way into the gut. So there could be gut-related genes that are related to anxiety, but also in the brain. And that just confirms in the most recent way, most recent evidence, that anxiety and IBS symptoms are very closely related. And you have to understand this connection if you want to treat IBS patients in a satisfactory way.
So it's not just a brain thing or a gut thing. It's this complicated back and forth between the two, making it this brain gut or mind gut disorder.
Yeah, and it's most importantly for the patients, I think, that they realize it's not a psychological disease. These genes that increase your vulnerability for anxiety disorders, that's not a psychological trait or a psychological diagnosis. It's just as biological what goes on related to these genes affecting the brain and the gut as anything else in medicine is. And I think patients for a long time were reluctant to accept this brain-gut model because they always thought it just reinforces the prejudice that many physicians had towards them. They would dismiss their symptoms
Not
as
this like it's just all in your head or
yeah. So
yeah.
it's interesting how this phrase "it's all in your head" initially it was taken as a dismissive argument that really upset patients, and rightfully so. In the meantime, when we say a lot of it is in your head, means it's in your brain and in these complex interactions between brain circuits that are involved in both autonomic nervous system regulation, pain sensitivity, and affective symptoms like anxiety and depression.
So speaking of complexity, despite the large number of published studies and clinical trials over the past several decades, we don't have an effective pharmacological therapy for IBS, and the prevalence has not changed. So, what is the explanation for that disappointing situation?
Well, I think the most likely explanation is that we have basically pharmaceutical industry over decades has focused their drug development on either the gut or in isolation on the brain, like the stress system, and it's not really accepted this bidirectional brain-gut model. I think that's the most likely explanation. I mean, we have been involved, our center has been involved in studies for the last 3 decades with the major pharmaceutical companies and with very ambitious, very expensive drug development projects. And the surprising thing is they have really not, even the most promising one, which was targeted at the stress response system in the brain, a compound called CRF1 receptor antagonists, were not successful. Still, a lot of people in the field that were involved at the time in these studies could not explain that. But I think the main reason was the limited pathophysiological model. I think today, for the first time, by incorporating the nervous system, the gut with its complexity, with its endocrine system, and the gut microbiome, I think we have now a new model, which is complicated, but we have a new model that I think is a much better basis for effective treatment developments. And what we have seen, for example, if you take IBS symptoms in general, not just like, for example, diarrhea or constipation, the most effective treatment approach is with behavioral therapies. So cognitive behavioral therapies, different gut-targeted variations of mindfulness-based stress reduction or gut-directed hypnosis have shown probably the best benefit so far of any therapies for the syndrome in general. We have treatments, like Imodium that can treat diarrhea very effectively. We have other treatments that can treat constipation quite effectively, but they do not affect this complex syndrome that we talked about in the beginning with multiple symptoms, both intestinal and extraintestinal symptoms. And the quality of life with these treatments will not improve because people will still have, a lot of symptoms that they don't feel comfortable. They have not reached a gut health that they are now aiming for and looking for.
That makes sense. So those are all the questions I have. Is there anything else you want to add? Leave on a positive note?
Yeah, so to leave it on a positive note, I would say it's taken a long time, and this research has gone down many directions that were not successful. I think you could say it's kind of disappointing that despite all these efforts, we have not really reached a point where we could say we know what IBS is and we know what treatments are effective, and we can actually tell a patient, we can actually reduce your symptoms by at least 50% in the long term. But the patient's role plays a big role in this. It's not the simple pop a pill and get rid of your IBS. That approach has turned out to be not successful. I'm optimistic that in the next decade we will see major breakthroughs. There's now also programs, major academic centers, including UCLA, the Digestive Wellness Program, or a combination, a holistic therapeutic approach, including dietitians, psychologists, gut-oriented psychologists, behavioral experts, and physicians are working together in dealing with this, with this syndrome. Yeah, I think it's the most exciting time in this development that I've seen. It's been frustrating for many years to see that the brain gut concept was not accepted by the majority of physicians, gastroenterologists, and that patients were sort of lost without a medical counterpart to their symptoms that would make them feel understood and that they trusted that they would, reduce their symptoms in the long term.
So it seems like it's trending in the right direction thanks to you and your group's efforts. Um,
Absolutely. Yeah.
yeah. All right, everyone. Thanks so much for tuning in. I know both of us really hope today's conversation helped you feel a little bit more informed when it comes to understanding IBS. If you want to go dive deeper into IBS or any other health-related topics, we have plenty of helpful resources at emeranmayer.com, including Dr. Mayer's in-depth IBS course, which is 70% off through the end of the month in honor of IBS Awareness Month. Take good care, and we'll see you in the next episode.